What's going on, everyone? I have something really exciting to show you. Before I show you this, I want to just tell you that if you have not watched our demo yet, which is a 30-minute behind the scenes, look at me in the mirror behind me, 30-minute behind the scenes walkthrough of our program, pre-recorded, go to demo.movenowyou.com, demo.movenowyou.com. This is David, David's physical therapy assistant. He's actually our exercise therapist, and he's awesome. If you haven't heard about David, it's kind of a big deal. He's like being humble right now. I'll show you some of the stuff that David has helped us put together. Ironically, we're almost wearing the same shirt, but not really. So like, let's give a quick little shameless plug for Cash Practice. We're big fans of Cash Practice.
Physical therapy, Bradlon.
So yeah, I know. Look at this, physical therapy assistant wearing a chiropractic shirt. That's awesome. Cool. I mean, and it's okay. It's not like it's chiropractic, against PT. There's a lot of stuff that we all do together. We're trying to help our patients get great outcomes and avoid drugs and surgery, right? So anyway, let me tell you a little bit of the background on this real quick. So we have functional movement tests that we've built called the MoveWell 3. Okay, so I'm going to turn and have a conversation with Dave, even though the microphone's right here, just so it's less of me just with this weird camera angle, whether you're watching this on a Facebook Live or on a podcast in the future. But basically, we have a movement assessment that we do. Technically, there's a screening first, which is level 1, to see does a person have any issues. So we take them through, we measure a bunch of movements, and we see does anything get flagged, right? Then if something gets flagged, then we go to level 2, which is then we break those dysfunctions down into their root pieces to then figure out why can't they move in these larger movement patterns functionally. If there's pain, we note it. If they're not moving within a certain set criteria, we note it. Or if they're moving really well, we note that too, and then we score that on a 46-point score. So that's the MoveWell 3, level 1, level 2. Part of the thing that we teach inside of our program, part of the thing that we do every single day here. By we, I mean David. Okay, so David does lots of these. He can do them in his sleep. And then we have a level 3, which is when you want to take one of the most complex movement patterns, which is an overhead deep squat, which is also referred to as a triple flexion movement, because you're flexing shoulder overhead, you are flexing hip in the squat, and you are also flexing your knee in a bend, okay? And technically, you're also dorsiflexing your ankle. So it's a triple, maybe quadruple flexion if you count the ankle.
Yeah.
You ever thought about that?
No, but that's true.
Quadruple flexion. Okay, so anyway, the level 3 breaks that down, and we have 5 functional faults, and all the stuff was named like this purposely just to make it fun. 5 functional faults, okay? That was a trainer Tonyism. Trainer Tony was here before he moved to a different city, and he helped us build a lot of this to begin with. And then we had Anabolic Andrew, and he's in physical therapy school right now. He comes back to visit sometime. Now we have David. Like, we've had this whole crew of people that we still work with and keep in contact with that have helped build this out and make it as awesome as it is. Side note, I'm talking all the clinical stuff right now. We also talk about all the systems of how to put this stuff together. But what I want to show you right now, which I put in the description above, which I am getting to, I promise, is that we have this level 3, which breaks out an overhead deep squat into the 5 functional faults. We break that down. It has like muscle length tests and just different correctives and differential diagnosis, not diagnosis of a pathology necessarily, but what's dysfunctional in the overhead deep squat. And then we have some protocols of how to fix it in more detail, which is really cool. We made a level 4. And the reason we're making a level 4 is not because like you only do it once you go through level 1, 2, and 3, but level 4 is extremity specific. And so I mapped this out for the shoulder. And then the really cool part and benefit of having David on board is he loves movement. He loves exercise. He's also a personal trainer. And so he gravitates towards this, and he's helped us map out some other stuff and done so in a really cool fashion. I'm going to share it with you. We have it laid out on a table right now, and I'll describe it. So if you're just listening to the audio on this on a podcast, you can let your imagination run wild of what you're looking at. So this first one here, this is the shoulder differential diagnosis. I made this a while back, and then it sat on the back burner for a while, and we're now revisiting it. So it basically, the whole purpose of this, and I'll spread this out so you can see, look inside of my crazy brain. So we have shoulder differential diagnosis. We have all the different orthopedic tests that we learned in school and forgot about and never use. But what we did is we paired those up into the most common evidence-based clusters. So for example, there's called Park et al. Cluster, there's Michener. These different clusters have been shown in the peer-reviewed literature to be much more either specific or sensitive, so aka reliable in one sense or another for getting an end diagnosis. Does a person have a SLAP lesion labral? Do they have a posterior inferior labral issue? Or do they have impingement rotator cuff, or is there an AC joint problem? So this is like the thought process as a reference. And then what we want to do is make that applicable in clinical practice to be able to have forms that you could check off and take your patients through these exams and then know what to do with them. So this is really, really small how we did this one because I crammed it all together on one page. But and all of this is not done yet. I'm just showing you what we've created. And by we, it's me and David, okay? And that's what we're meeting for right now today, is to start sorting this through and figure out our next step before we launch this to all of our MoveNow chiropractors so they can use it in practice. And we can use it in practice, okay? So we still practice full time. So you have level 4 shoulder, and if it's rotator cuff, labrum, or AC joint, we break down all the different tests. This is really that small. See, it's like really small, my fingers next to it. I shrunk this down just so you can see the bird's eye view stuff. But how this looks is like, how do we do? I think there's more of these inside. Oh, you know what? It just prints that small in Lucid Charts because this was one of the, this was like 6 pages really. Yeah. Is why it printed like this. Yeah. Okay, gotcha. So what it does, it takes you through these tests, and if it's positive or negative, it shows you, okay, you go to the next test, and then what we're going to have this spelled out with is you can go through a series of like shoulder orthopedic tests and actually get some really good data to say, here's what's probably wrong with this patient. So here's the intervention we're going to use, okay? This over here was breaking down, this is another chart that I'm showing you, it's just breaking down all the functional anatomy, just a good reference of organizing all the anatomy stuff that we all learned in school, and some of us remember and retain, and a lot of us only remember pieces of it, but it puts it into a functional model of how to understand how it relates to movement, and when people are screwed up, what tissues are probably screwed up, okay? This one then goes over, and this is another one, talks about all the different movements of the shoulder. So you have shoulder external rotation, internal, horizontal adduction, abduction, shoulder adduction not in the horizontal plane, shoulder abduction not in the horizontal plane, flexion, extension, protraction, retraction of the scapula, scapular elevation, depression, and scapular upward rotation and downward rotation. Those are actually all the movements that occur in the shoulder. And then we talk about what muscles in that are overactive, which are underactive, and then the functional movement neurological activation order of operations based on what the best studies and research out there show for clinical outcomes. And then how you do a release, you inhibit the overactive muscle with a certain movement, and then what you activate. So anyway, I know that's a lot to listen to if you're not watching this. Even if you are watching this and you're seeing it, you're like, what is he talking about? But this is how we organize stuff. Just making sure everything clinically is very complete before we build something out. So there's a lot behind the scenes before we introduce something to our tribe of doctors. So that was shoulder. Then we have hip special tests. So in hip, I'm going to flip this around real quick. So in hip, really like everything outside the shoulder, the orthopedic tests really don't give you necessarily a differential diagnosis. It just helps you get closer to understanding what's going on with them as far as what tissues and things are responsible for the person's issue. Shoulder is a lot more of a differential diagnosis end play. All the other stuff is more or less, it guides you, but it's not as conclusive, and that's no fault of ours. That's just how the tests are designed. But this is something that we're going to figure out how to keep shoulder a little separate, because it does have some more concrete differential diagnosis data that it leads to, and then the other stuff is just, there's still some unknowns. There's still some special imaging and things that can be done within the process if you see certain red flags. So we have hip special tests. I'll flip this around one more time. I'm not going to go into all the details, give you the overview. We have hip special tests. So we talk about different pathologies, pathological weakness. There's a red flag spot here. And then this is probably what we'll be using as the doctor's standpoint when a patient comes in. So let's say they have a hip problem. You pull this sheet out, and then you start working through it. And you go through this, and based on what you find, we'll have a spot here to say like working diagnosis and then what protocols to use. And we'll have some acute protocols that we'll organize and build out for shoulder, specific to what we find, hip, SI joint as well, so more so on top of just adjusting them. Okay, so definitely we make sure that they get adjusted specifically, but more of understanding what else, if there's any sort of like real bad SI joint injury that needs some sort of rehabilitation intervention. Knee, okay, so in knee we have more of, is it a patellofemoral tracking problem? Is it a meniscus? Let's see, what else do we got for knee? And then knee special tests, like is there a possible fracture of the patella? Okay, and then come on over here, we have ankle. And so ankle, we're looking for, pronation, impingement signs, ligament tests. All right, all the flowchart process. So granted, all this is going to have videos explaining every step of the way, and we're going to figure out what else we need to build out to make this complete. And then knee. And knee is MCL, LCL, PCL, ACL. And of course, the patellofemoral and the meniscus. All right, and then, did I miss anything? That's it. Okay, cool. So just wanted to show you what we're working on. That's why we got together right now, is to try to figure out what the next thing we need to design to organize all this and what videos we have to make. And we'll start making a video shot list, and then we'll come in and film all the videos at one point. I've learned that. And I spoke too soon yesterday when I was like, hey, we'll meet and we'll shoot some videos. And it's like, we might make like one video or something that we already know we're going to shoot. But for this, how it always works is we come in here, we start setting up lighting and cameras and everything to shoot. And then we end up spending like 3 hours just discussing and mapping stuff out. So there's a lot of thought that goes behind this before we can actually start shooting video and organizing the content. Last thing I'll say, in the beginning, I talked about making sure you watch a demo of MoveNow University inside the Doctor Portal. It's demo.movenowu.com. It'll send you a link right to your inbox so you can watch at your convenience. And it's a 30-minute pre-recorded demo. It shows you how all the stuff works inside, so you can see how you as a doctor is going to see it, how your staff's going to see it, as far as when they start training and implementing these systems in practice. But another thing that is also in the description of this above, and depending on when you're hearing this on a podcast, it might not be relevant anymore, but we're doing a thing for Black Friday. So if you want to know what's going on Black Friday, click on that link, get on the list. We're doing what's called Move Now hookups. We did this last year, do it for a very small window during that Black Friday time when everyone's crazy and buying their toasters and microwaves and shake weights and all the stuff they want to get, right? Likes the shake weight. Okay. Anyway, make sure you check that you click on that link and get added to the list, and then you'll be the first to know once we tell you what the Black Friday special is going to be. All right, so I promise you, David normally talks more than this. I'm just stealing all the thunder right now, but what's that?
I'm a mute. I know.
He's a mute. Yeah, he's a mute. Didn't say anything. Anyway, all right, over and out. We got work to do. Talk to you soon.